We're going to talk about hepatic disorders, which includes all the viral hepatitis, non-viral hepatitis. We're going to get into a little bit about infection and infection control as well. So talking about the liver, liver function is complex and hepatic dysfunction affects all body systems. For this reason, we must understand how the liver functions and must have expert clinical assessment and management skills to care for our patients that are undergoing complex diagnostic and treatment procedures. We must also have an understanding of technological advances in the management of hepatic disorders. Liver disorders are common and may result from viruses, obesity, and insulin resistance, or any exposure to toxic substances such as alcohol or even tumors. A short little review of the liver here. You may want to go back and just review your pathophysiology of the liver. But it is the largest gland of the body. It's located in the upper right abdominal area. It allows the liver to receive blood from the GI tract via that portal vein and from the hepatic artery. From there, it either stores or transforms nutrients into chemicals that are used elsewhere in the body for metabolic needs. The liver is a chemical factory that manufactures, stores, alters, and excretes a large number of substances involved in metabolism. The liver is especially important in the regulation of glucose and protein metabolism. The liver manufactures and secretes bile, which has a major role in the digestion and absorption of fats in the GI tract. The liver removes waste products from the bloodstream and secretes them into the bile. The bile produced by the liver is stored temporarily in the gallbladder until it's needed for digestion, at which time the gallbladder empties and bile enters the intestines. The liver stores glucose, fat-soluble vitamins, folic acid, vitamin B12, copper, iron, regulates glucose and cholesterol. It purifies, transforms, and clears toxins, drugs, and hormones. It synthesizes and secretes clotting factors, transporter proteins, cholesterol, bile for digestion, and glucose. It metabolizes carbs, fats, and amino acids. The liver does produce those phagocytic Kupffer cells, which engulf harmful bacteria and anemic red blood cells to carry it out of the body. It detoxifies potentially harmful substances for excretion by the kidneys. So here you will see a lot of things that are stored in the liver. Vitamins A, B, and D, and some of the B complex vitamins are stored in large amounts in the liver. Other substances such as iron and copper are also stored in the liver, and because the liver is rich in all of these substances, liver extracts have been used for therapy for some nutritional disorders as well. So these are some of the more common LFTs, liver function tests, that you will see performed on your patient. That table 49.1 in your book will kind of break it down and tell you what each one is testing for. But as you see there, that serum aminotransferase, those are usually used to determine how much damage we have to the liver. We'll do serum protein studies, that bilirubin. A lot of times you will see it increased when you start seeing patients with jaundice. That prothrombin time will determine your bleeding time. And if you will refer to table 49.1, you can get into more detail about each of these lab functions. So these are some additional diagnostic tests that we can do if if your lab testing is not diagnostic. So most of the time we're going for that liver biopsy. That's the most definitive test, and it identifies that degree of tissue damage. The major complication with that is your peritonitis, which is when the blood or bile after your biopsy becomes drains into the abdominal cavity, and it can cause infection. It can even cause death. X-rays can show us ascites, hepatomegaly, that enlarged spleen. EGD is used to see the esophageal varices. We can do ultrasounds, MRIs, EEGs, all of those things. And that chart on that chart 49.2 will go into detail with all of those. So some common medications for your hepatic disorders, of course, antibiotics, but we have to be careful because if our liver is not metabolizing those medications, it can build up in our bodies and cause non-viral hepatitis. With the jaundice, patients often complain of itching, so we may use some antihistamines, Benadryl, Questrin. With hepatitis, we do our antivirals. As you see there, we're going to replace those vitamins there that our liver normally stores, which if our liver is not functioning properly, we may not get the storage of those vitamins. With ascites, you may see some of these diuretics. If it's bad enough and we have encephalopathy, you're going to see the lactulose or neomycin. And to promote bowel flow, you're going to use that USDA and the URSO. So what can cause our liver dysfunction? Acute or chronic cirrhosis of the liver. Your most common cause is malnutrition related to alcoholism, infections, anoxia, metabolic disorders, again, nutritional deficiencies, and hypersensitivity states. What are we going to see? What's our patient going to look like? In the later stages, we're going to see jaundice. You may see that portal hypertension, ascites, and varices. Portal hypotension is the increased pressure throughout the portal venous system that results from obstruction of blood flow into and through the damaged liver, commonly associated with hepatic cirrhosis, but it can also occur with non-cirrhotic liver disease. Splenomegaly with possible hypersplenism is a common manifestation of portal hypertension. The two major consequences of portal hypertension are ascites and varices. Your esophageal varices are dilated, tortuous veins that are usually found in the submucosa of the lower esophagus, but it may develop higher in the esophagus or extend into the stomach. This condition is almost always caused by portal hypertension, which results from obstruction of the portal veins within the damaged liver. Viral hepatitis is a systemic viral infection in which necrosis and inflammation of liver cells produce a characteristic cluster of clinical, biochemical, and cellular changes. There are 5 definitive types of viral hepatitis that cause liver disease, which are hepatitis A, B, C, D, and E. Hepatitis A and E are similar in their mode of transmission, which is the fecal-oral route, whereas hepatitis B, C, and D share many other characteristics. The table 49.4 will kind of show you the differences between each type of hepatitis. I'll let you read this slide, the pathophysiology, and I will discuss a little bit more on the next slide. And you can follow this chart down, but basically you have your causative agent, which is viral, toxin, or alcohol, which causes damage to the hepatocytes by the body's immune response, creates that altered cellular function, it causes changes in the endoplasmic reticulum, responsible for protein and steroid synthesis, down to the alteration in liver functions depending on these processes, produces these Kupffer cells, they increase in size and number, causes that liver to become inflamed. You get some increased white blood cells, you get that tiredness, nausea and vomiting, pain, fever, anorexia, you get alterations in blood and lymph flow, decreased vitamin K absorption, show that bleeding tendency or decreased bilirubin metabolism and or obstruction. You get that conjugated, unconjugated hyperbilirubinemia, which causes the jaundice or that decreased bile in the GI tract and increased urobilinogen, and you get those clay-colored stools and that dark urine. Complications, as you see, the fulminant hepatitis and the chronic hepatitis. The fulminant is the failure of the liver cells to regenerate themselves, has a progression of necrotic process. It's rare, but it's often fatal. And that chronic, what is chronic? More than 6 months. It's usually a result of hepatitis B or C, and chronic active may lead to liver failure and death. Again, system-specific assessments, you may see that jaundice, which is your icteric phase, the pruritus, that itchiness. You're going to assess the vital signs that may show a low-grade temperature. What is your urine going to look like? We talked about that. It's going to be that dark, almost tea-looking color. They're going to have their nausea and vomiting, not wanting to eat, that fatigue. Again, we talked about the clay-colored stools. They're going to complain of that right upper quadrant pain, some tenderness. They may have that muscle and joint pain. Later stages, they're going to have some edema, maybe ascites, that enlarged spleen. We're going to watch their weight and watch their I's and O's. All right, so how are we going to treat them? They have fatigue. They have some tenderness, maybe some muscle aches. They can't eat. Sometimes they have nausea and vomiting. So how are we going to treat them? We're going to let them rest, decrease that metabolic demand on the liver. Their diet is going to be high in carbs and calories, getting the calories in. We're going to do a moderate protein and fat, because what is the liver doing? We're going to try and decrease that workload on the liver. We're going to recommend small, frequent meals, avoiding fatty and fried foods, and getting about, increasing their fluid intake, so about 3 cc's of fluid during that acute phase. Going to relieve their nausea, give them antiemetics, vitamin supplements. We're going to give them pain medication if needed, comfort measures, good mouth care, being careful with injections, good skin care. Why is that? Because we may be affecting those clotting factors. We don't want to bleed, cause any excessive bleeding, anything like that. Watching their I's and O's and weight, and get any vaccines that they need to get at this point. So this just talks about their nutritional needs: moderate protein, high carbs, moderate fat, getting those vitamins in, getting that iron and copper in. What kind of teaching are we going to do? We're going to tell them to avoid those over-the-counter meds unless the physician okays them. Avoiding any alcohol, keep on resting, making sure you're getting those calories in, and avoiding sex until those screens come back negative, so we're not passing it on to our partner. How are we going to prevent it? Adequate sanitation and personal hygiene, being clean. How is A&E transmitted? Through fecal oral. Well, we're not going around eating feces, are we? No, it's because people that are infected are using the bathroom and not washing their hands. It's really nasty. And then they're preparing food, and the person who eats the food that's prepared by them is ingesting the fecal matter, which then transmits the hepatitis. Making sure our water is treated by a purification system. When traveling, avoiding foods washed or prepared with tap water. That's when you go out of the country and people say don't drink the water, because their purification systems may not be as advanced as ours, and it's mixing and getting feces in the water and then transmitting that way. Not sharing bed linens, towels, eating utensils, drinking glasses, and not sharing needles. This is just a little helpful sheet to kind of put it all together. So with hepatitis A and E, fecal oral route, there is a vaccine for A, but not for E. There's a vaccine for hepatitis B. We've all had that one, hopefully. B is transmitted with blood, semen, saliva, so all those body fluids. Hepatitis C is blood and semen, think circulation. Hepatitis D is a superinfection, so they have to have B in order to get D. And again, that's transmitted through blood. And there's some signs and symptoms, our treatment, and our diagnosis. Okay, this just breaks down hepatitis A, tells you again how it's transmitted. It can live in the body before seeing any symptoms 15 to 50 days, so you may not even remember where you picked it up at. Your illness may last 4 to 8 weeks, so we get those mild flu-like symptoms with that low-grade fever, we not want to eat. Later on, we get some jaundice, dark urine, epigastric distress, and that liver and spleen maybe start becoming enlarged. Again, how are we going to manage it? Hand washing, making sure we get a vaccine, immunoglobulins, bed rest, nutritional support. Hepatitis B transmitted through body fluids. This is a major worldwide cause of cirrhosis and liver cancer. If you look on that chart 49.9, you'll see the risk factors. It's a long incubation period, 1 to 6 months. So by the time you start seeing signs and symptoms, you may not remember where you picked it up at. Manifestations are insidious and variable and very similar to hepatitis A. So we're going to manage it pretty much the same way. So medications for chronic hepatitis B include those alpha interferons and antiviral agents. Bed rest, nutritional support. Again, those at high risk should get the vaccine, so we have all been vaccinated for that. Hepatitis C, blood, sexual contact, including needle sticks and sharing of needles. This is the most common blood-borne infection. A cause of 1/3 of cases of liver cancer and the most common reason for transplants. You can look up some risk factors, usually mild symptoms. A lot of times people are walking around, they don't even realize they have hepatitis C. How are we going to manage hepatitis C? There are antiviral medications for reducing the spread of infection. Stop drinking, no alcohol. Talking about prevention, screening, safety needles for healthcare workers, and they have new treatments now for those with hepatitis C. So they're showing a dramatic improvement in the treatments for hepatitis C. You may have seen the commercials on TV about the baby boomers trying to get them to get tested so they can get treatment. Hepatitis D, like I said earlier, only those with hepatitis B can develop hepatitis D. These are the ones that are more likely to develop those complications like the fulminant liver or chronic active hepatitis and cirrhosis. Again, transmitted fecal oral route, incubation period 15 to 65 days, resembles hepatitis A, and so we kind of treat it the same way. It is self-limiting, kind of an abrupt onset, and it's not chronic. So certain chemicals have toxic effects on the liver and produce acute liver cell necrosis or toxic hepatitis when inhaled, injected parenterally, or taken by mouth. The chemicals most commonly implicated in this disease are carbon tetrachloride, phosphorus, chloroform, and gold compounds. These substances are true hepatotoxins. Many medications can induce hepatitis but are only sensitizing rather than toxic. Drug-induced hepatitis is similar to acute viral hepatitis, but parenchymal destruction tends to be more extensive. Medications that can lead to hepatitis include isoniazid, halothane, acetaminophen, methyl-dopa, and some antibiotics, antimetabolites, and anesthetic agents. So here are a lot of medications that can be toxic to the liver. When us as nurses, when we're administering medications, we need to make sure that we're verifying orders when those hepatotoxic drugs are ordered for clients with liver disease. We're watching those LFTs, those that are sensitive to the liver. We're making sure that we're watching them and making sure we're not hurting our patients. We need to notify the doctor of any adverse effects or abnormal lab values and educate our clients, our patients, on signs and symptoms to report to the doctor. So these medications, you have your ACE inhibitors, acetaminophen, alcohol, your NSAIDs, some of those antibiotics on there. So we have to be very careful with these. They're very sensitive to those that are already with liver damage. So those with toxic and drug-induced hepatitis, you may notice some nausea and vomiting, anorexia. You may notice some jaundice, chills, fever, rashes, the itchiness, vomiting blood, those clotting abnormalities. You may notice those little hemorrhages under the skin. And for treatment, pretty much a lot of times, if they're on a medication or a drug that has caused it, stop giving it, and they start getting better. If the reaction is severe, there are very few treatment options other than transplants. All right, so what is an infectious disease? Pretty much any disease caused by the growth of pathogenic microbes in the body. May or may not be contagious. Modern science has controlled, eradicated, or decreased the incidence of many infectious diseases. However, increases in the incidence of other infections, such as those caused by antibiotic-resistant organisms and emerging infectious diseases, are of growing concern. A complete chain of events is necessary for infection to occur. There are 6 elements that are necessary, including a causative organism, a reservoir of available organisms, a portal of exit from the reservoir, a mode of transmission from the reservoir to the host, and a mode of entry into a susceptible host. So that right there shows you that chain of transmission. So any break in that chain can stop that transmission. So what are some infectious diseases that we see a lot of? C. diff, flu, MRSA, VRE, tuberculosis. We see a lot of those. So how are we going to prevent them? What is standard precautions? Hand hygiene, personal protective equipment, proper handling of patient care equipment and linen, environmental control, preventing injury from sharps devices and patients' room assignments with healthcare within the healthcare facilities. So we're doing all of these things as our standard precautions. A lot of times we're doing them instinctively and not even realizing it. So when our patient has a infectious disease, we need to increase our precautions and go into isolation precautions. So there's contact, droplet, and airborne. Your contact precautions are used for those organisms that are spread by skin-to-skin contact. That's going to be like our C. diff and our MRSA. Droplet precautions are used for organisms such as influenza or meningococcus that can be transmitted by close contact with respiratory or pharyngeal secretions. Airborne precautions are required for patients with presumed or proven pulmonary TB, varicella, or other airborne pathogens. When hospitalized, patients should be in airborne infection isolation rooms that provide negative air pressure, rapid turnover of air, and air either highly filtered or exhausted directly to the outside. Healthcare providers should wear N95 respirator at all times while in the patient's room. So those that work in the Palmetto Health setting, you guys get fit tested for those N95 masks. And so they make sure that those masks, you are being protected when you're in that patient's room. If you have not been fit tested, you should not be going into a patient's room that has TB. Those of us at Lexington Medical Center, we're not fit tested. Students, we're not fit tested, so we should not be caring for patients with TB.